at this time, I would like to introduce Dr. Alex Laungani. He is a plastic surgeon at GRS Montreal to do a talk on foundations in surgery. This session will go until noon, so part of it will be a lecture, and the other part will be question and answer. And when you receive your decks from this course, there will be no pictures in the decks. No patient pictures whatsoever. So it's really important for you to know beforehand. There will just be line drawings, or if but there will be no pictures. And also, it's really important that you don't take any pictures during this or videos during this session because to protect privacy. So, great. I think we've got 3/4 of the people, and everybody's continuing to come in. So I will now start and invite Dr. Laungani to come and start his presentation. So thank you, Alex.
All right, good morning, guys. So we're going to try to make it a little bit interesting for you if you're not even in the surgical field. What we're going to be touching upon is a very general knowledge on a multidisciplinary approach to this type of surgery, and then a little bit of SOC 8, although I didn't have time to read it overnight. Feminizing surgery, masculinizing surgery. So it is very important, and you hear that a lot. Multidisciplinarity is key as an approach in general in many different fields, but definitely for gender affirmation surgery. We need to have multiple providers involved. And so you'll have the surgical specialties such as the plastic surgery, urology, OB-GYNs are also involved, oral and maxillofacial surgery as well for facial feminization surgery, and ENT doing some of the voice surgery programs. But there's, of course, that's just to talk about the surgical multidisciplinarity. There's many different fields also before getting to surgery. What the SOC 8 mentions a gender surgeon should be or do is have a training and documented supervision in gender affirming procedure, which means we've seen a growing number of programs throughout the world of gender affirmation, probably with a lack of training or not proper training for now. And so, better care, any care was better probably than no care. So it did allow individuals to have access to surgery, but it's time just to make sure that we have the right training and that everybody has the same standard, because the patients deserve it. And so we need to make sure that we'll build these training programs, fellowships and things, and it's really happening now. So this is going to be something mandatory. Maintenance and active practice of gender affirmation. Well, you do great only what you do often, right? So if you do a vaginoplasty every 2 years, I don't think you could consider yourself proficient. You're going to have more complications. You're not going to follow up. You're not going to, and probably you're not going to be that interested that you actually go and hang out in this kind of conferences and learn from your colleagues, because you're not going to do it as much. So I think you need to dedicate a huge part of your practice to gender affirming care if you're going to do it at all. Knowledge about gender diverse identities and expression, I think, and I said it yesterday for the advanced course, and that's my first disclosure to you. I am no perfect, okay, and I will make mistakes, and sometimes I don't know the terminology, and I keep learning, and it keeps changing, but I try to educate myself as much as possible. If I make a mistake today, just correct me, let me know, and teach me. We can all learn from each other. So that's something important, and surgeons have to do that job also of learning what's happening in the other fields, because we all work together. We can't just be in the OR and pretend nothing is happening outside. Continuing education, well, this is what we're doing now. And then tracking of surgical outcomes, that's very important in a world that does not have many different centers for now still, so we have patients traveling, and we need to explain to them that it's going to be very important to keep coming back, or to have some sort of follow-up, so we can track the outcomes, and so we can review our own techniques, and we can at least try to improve some of those techniques. And so those are all the different providers I was mentioning earlier. Of course, there's many more than just the surgery. So, it usually starts with hormone therapy, and you may have had already the endocrinology talk about redistribution of body fat and muscle mass when we're talking feminizing here. Breast growth, which will continue for 2 years. So that's, for example, important to know. It doesn't mean that you wouldn't do a breast augmentation before that, but if patient asks, am I expecting to see more increase in my volume? Well, potentially yes. So do you want to wait? Maybe you'll be happy with that. Maybe you won't have to put an implant if you're happy with the breast growth you have. I've seen actually quite some impressive growth with just the hormones, and patients being very happy. Vaginoplasty patients that I operated on that didn't want to have any breast augmentations because they were fully happy with their native tissue, which I think is great. And then the hair pattern, of course, slowing and reversing of the hair loss. This is a little bit of a table to give an idea of the timelines that we're talking about for expected effects of the hormones. So the standards of care, to me, everybody has its own probably way of seeing it, but I see it as a GPS. When you go somewhere, you may know perfectly the road, and then you don't even have to look at the screen, and you're fine. But if you get lost somewhere, if there's a roadblock, and then you don't know, you just put the GPS back on, and then it gets you to the point. So it means that it's made as to help you move towards the pathway, to help you move towards the patient goals, to help the patient reach their goals in a very safe way. And if you're getting lost along the way, you can just go back to that and make sure that you actually check the boxes, because that's probably the safest way to do it. Does that mean that we have to stick perfectly to it? Probably not, because I do surgery on younger individuals for top surgery, for example, for gender-affirming mastectomies, and I think it's warranted when they have parental support and when they're just miserable at home, not going to school, and the right thing to do is to remove breast tissue so they can be re-socialized. So that's just an example. So in the surgery chapter, as far as apparative, you'll find that now, so the assessment letter still, but we've been discussing, talking to patients about breast cancer screening, both for mastectomy and augmentation. It's very important. You got to choose the right wording. You can't really, you can't talk about breast to a trans guy who's going to feel very bad about himself hearing breast, but you can say tissue, you can say lumps and bumps, you can say self-palpation screening, so they'll get what you mean. You have to discuss reproductive options when we're doing gonadectomies, of course. It's a lot of things happening in one's life at that moment, and we tend to rush things to get to that surgery, but there could be regrets afterward and saying, well, it could have been an option actually to freeze some of that, and so I think it's important that we mention it at least. There are still financial issues associated to that, because in Canada, for example, I think the 5 first years are covered, but then you would have to pay for storage after that. So if we're talking young individuals, maybe they won't have the money to do so, but at least you have the conversation with them. Still hormone therapy advocated for genital surgery. Surgery eligible adolescents, like I said, I was already doing it, and I think that's something I definitely agree with. And we say multidisciplinary approach because it's important that everybody's involved and that we do the right thing for those kids. But so you don't want to rush into things, but definitely you should consider individually customized surgery. What does that mean? Well, even as validating as we were trying to be, we were still very dichotomic in the types of surgery we were offering, either trans male, trans female, going from one side to the other, blah, blah, blah. Now we have a better understanding also what it means to be non-binary, and that requests can vary, and you can have multiple procedures that don't necessarily fit towards going to one side or the other. And so this is what we call the customized surgeries. And I think you should incorporate that into practice as well and see what the goals are, so you can answer patients' expectations. And then the aftercare, that's what I was saying about patients traveling a lot and needing to, so you need to have this conversation. How are you going to do it? We need to arrange for either it's teleconsultation, phone, emails, but you need to track patients and to make sure that they're okay after surgery. We do advocate for a lifelong follow-up with a primary surgeon. So the plastics or urologist, primary care physician can take the lead on some of that as well. And gynecologist and urologist as needed. It's probably a very good idea for vaginoplasty patients to have a gynecologist and for a phalloplasty patients to have a urologist involved. You'll see for phalloplasty, that's something you probably know already, it's a lot of complications. And so those complications need to be seen and need to be followed, and we need to have the patients along the way. So this is just a summary again of that. Content of letter, I think you guys know that, so I'm not going to go back to this. When we talk about, medical necessity insurance coverage, those are two different things. You can be considering that it's medically necessary, but then depending on the country where you're from, it could be covered or not. And people tend to make a line between what they consider cosmetic versus reconstructive. I think in plastic surgery, the line is very thin sometimes. And I actually wrote a paper a few years ago saying, should we consider a cosmetic or reconstructive procedure, gender affirmation surgery? And of course, to me, it should be considered reconstructive in the sense that it should be covered. And I think that, the way I was explaining that to people was to say, we are at a point where we're asking ourselves if we should face transplant some individuals that were completely burned and blind. And so it means that we do understand that their interaction with the world actually changes because of their face, even if they're blind, right? So just for the sole purpose of that dichotomy, I said, well, can you imagine not having the body that you should be in, and now your social interactions are not going to be great either. So so definitely we should go towards that direction. And I wrote that because I was very angry actually at the editor putting all the papers of gender affirmation in the cosmetic section. And I said, if you keep doing that, what's going to happen is that someday some insurer, and especially now, seeing what happens in the US with a lot of fight backs, some insurer is going to say, well, if it's cosmetic, we're just going to stop covering it. And that's a huge danger. So, we definitely the SOCA does consider even facial feminization now as medically necessary. We'll see if we have changes in the insurance policies in the next few years. This is what I'm hopeful for. Another problem with the insurance is that it uses old codes and codes that have not been adapted, and so you have to bundle some codes for it. And so you take codes, you put them together. Some people don't understand. For example, for vaginoplasty, we have to lengthen the canal, and so we use a skin graft. So we have to code for a specific skin graft. The coder doesn't understand that. They're like, well, you're in the genital area, you did a vulvoplasty, why do you need a skin graft? Well, let me explain it to you. And so, we need to rework on those codes and make sure that it does apply now to what we're doing. And I think there's a huge work to do on that. I'm not involved. I don't even know how to get involved with the CPT coding, but I think it's going to be a task that maybe WPATH will take on. All right, so we'll start with the face here. There are several differences that you may notice from cis males, cis females, that, as far as what we usually look at is the upper third, mid third, and lower third of the face. So if you want to analyze a face, this is how you should probably be doing it in a very systematic way because it's easy to do, and then you always can look at that. So the upper third, we're really talking about the forehead, the length of the forehead, the hairline, and then do you have a frontal bossing? Frontal bossing is what you will find in individuals assigned male at birth. Moving on then to the mid-cheek, you'll have more higher zygoma, you'll have more volume on the cheek in individuals assigned female at birth, and so a little bit less volume there, and more elongated face in individuals assigned males. And for the jaw, you'll have a wider chin as well as more angular jaw. That being said, I was showing a picture at a different course yesterday of Angelina Jolie and Brad Pitt, and she has a more angular jaw than he does, and yet she's still very pretty. So it's very individualized too, and it's what you value, what you want to move towards, you know. So it's not the surgeon who's going to say, well, I'm looking at you and this is what this and this and this that you should have, but more, what would you like to address in your face? What do you think? What bothers you? And then we can go and customize it. It doesn't mean that, again, one size fits all and that they're going to have all the different possible surgeries. But we can do a bunch. And again, it's going to be multidisciplinary because you're going to have mental health management, especially for facial feminization, because it could change really your interaction. It's going to change your face. So you got to be ready for a new face. And this is something that if you're not, societal response, family, employer, all of that, this is going to be seen right away. You can't hide that under your clothes. So you got to be ready. Get stylists, your hair. Are you going to do your hair, makeup, and all this kind of stuff that you may want to address at the same time. Hair removal, because what are you going to do with your pilosity? If you still have a little bit of beard pilosity, how are you going to tackle that? Do you want to tackle that? Or do you want to live with maybe a growing beard? It's okay, but you have to define that. And then see what the hormones have done for you to this point and what surgery, is going to do for you. We had the surgical dinner yesterday. It was crazy. So this is why, yeah. I'm still fully here, but my voice is half here. And then for surgeries, we have structural surgery, so we touch on the bone and the frame, and in soft tissue, we kind of redrape on top of the frame that we'll be working, and I'll explain that to you. So the structural surgery means that you can work on the bone, so you can remove pieces of bone, you can recontour some bone, you can change the shape a little bit of bones by doing different things. So either you cut or you use a rotating burr. You have a picture of a rotating burr here, very fast speed. That will, if you just go on top of bone, will just reshape, remove very superficial layers of bone in a very powder of bone, if you will, until we have a very nice smooth, for example, to smoothen an angle. You can use also bone grafts, and the bone grafts from different sites and from cadaver as well. You can use cartilage, and to do these types of surgery. Hi, Marcy. To do this type of surgery, 3D planning is really super important. Why? Because it allows patients to kind of see also what it would be looking like. So pictures a little bit of what the expected results can be, but also for the surgeon as guiding tool, because then you'll create cutting guides, for example, that are custom made based on a CT scan of a specific patient that then you would be using in the OR, so that your cuts are very precise to get to the desired result. So those are examples. You see here that frontal bossing, we see very well. This is a 3D reconstruction of a CT. And then at the same time, you have to address that frontal sinus that's right here in the middle. So it's that black spots here between the two layers of bone, that's the sinus. The sinus is essentially just in a closed air cavity. And so depending on the thickness that you have at the very anterior table, which means at the outer for you, what you're seeing on top, if this is enough as a thickness that you can just burr and contour, you can just do that. Or you can put some material on top of it to sort of like a cement to make it more smooth. Or because it doesn't work because it's too thin, you have to take it off, recontour it on the back table, and then place it back with plates and screws. Why? Because if you don't address that very well, this sinus is mucus producing, and you will have what we call a mucocele, which is a bad problem because it could get infected. And so you want to make sure that this is well addressed, and this is why there's classifications for that, and we'll have different types of surgery. If you hear different types of frontal bossing management, this is where it's from. Look at the difference between the two jaws here. You see one that's very wide, and you see the jaw that's been recontoured. So we can't see really well here, but even the angles have been touched, but you can see that the chin here definitely has been contoured. Soft tissue surgery, well, once you've done once you've worked with your frame, you can then be adding a bunch of different surgeries on top of that. So you will work the skin, you will work the fat, you will work the deeper layer of the face, what we call the SMAS. I don't know if you remember actresses maybe in the 80s, 90s that looked very pulled when they had a facelift. It was just terrible. They were just like this. It's no longer what we do now. We try to make it more discreet, and because there's a better understanding of the anatomy. And so we lift the skin, and then we get to the fat that's just underneath the skin. And then underneath that layer, you have the SMAS, which is really the inner skeleton, the soft skeleton of the face. And that you can pull on. You can put a bunch of stitches, you can tighten that, and then redrape the skin gently so there's no tension on the skin. But the tension is rather in the deeper tissues. So that's one of the techniques for facelift. You can use, you can do contouring of the body with liposuction and not throw the fat away. You can use the fat, centrifugate it, and then re-inject it in the face, for example, where you're missing volume. So instead of using an implant, you could be using your own tissue. And so that's been working great. You could use little flaps, so you could be doing transposition of adjacent tissue, for example, fat that you would have in the cheek as well, and put it somewhere else, and things like that. Example here of, again, so you have a pre-op and a post-op, the different views picture. With a hairline advancement, you see that the hairline pattern is different from the upper to the lower views. Brow lift to open and also to give a little bit of more feminine aspect to the brow. There's papers even describing the anatomy of a brow depending on the gender. So you may want to achieve that look a little bit more angular at the end of the brow here. Frontal bone reduction, and here in this case, so the sinus setback. This is what it means. Now you know. And rhinoplasty typically, so the cartilage is more. I would say beefy, and so you want to reduce the cartilage. You want to rotate the tip a little bit up, and curve a little bit of the dorsum of the nose to give it a more feminine appearance. This patient also had that fat grafting I was mentioning, just to give a little bit of more cheek volume here that you may notice, and then the genioplasty, that's addressing the chin. What are the risks of this type of surgery? Of course, we're cutting and dissecting and elevating tissues, and there are structures around that you could hit as you're doing that, and some of the nerves, mostly sensory nerves, actually. So, looking at the scalp, for example, or even on the face, it's rare to involve like a motor nerve on the face, because the facial nerve that moves the face is really deeper to the deep structure I was mentioning that you can pull on. Some facelifts do involve seeing those nerves, but you should never be really at the level of touching those. So it's mostly sensory. And for the most part, if you know that you've respected the anatomy, that you haven't cut a nerve, it's gonna come back. It's just temporary. So you want to counsel and advise the patient and tell them that you'll wait and do just conservative measures. In very rare cases, it could be permanent, but usually you would know during your dissection that you had an issue that you could have maybe divided the nerve. Mucocele, we talked about it. That's when the sinus is not well addressed. And then the anterior table, that's when it's too thin. That's why I mentioned earlier. Alopecia is, when we get to the face, the most common access to get to the face is really a big incision line here going in the scalp. So you can deglove all the face going down to the mid-face here. And of course, that big line here goes through the hair follicles. You can try to angle your blade to be parallel to the hair follicles so as to spare them as much as possible. But you will have some level of alopecia, which means no growth of the hair, so it'll be bald at that spot on the incision line. And this is why the incision is never a perfect line. We make it like a little V. And it's very discontinuous like this, just to make sure that we won't see that big line, but that will have some regrowth here and there, so that the overall aspect is actually not going to be bold. Breathing problems after rhinoplasty, that's pretty common. Like I said, Gail was there yesterday. I can tell you a bunch about this. I had 2 rhinoplasties and I still can't breathe. So that adds on to my voice problem. I'll be okay. And skin necrosis. So every time you elevate the skin, every time you work on the skin, you want to make sure that you keep the perfusion to the skin. For us, in plastic surgery, it's always keeping little arteries, making sure we can move things around, but making sure that it's going to survive. So flaps, we'll talk about flaps later. It's going to be about just keeping the blood flow to a piece of tissue. If you don't have that, then the skin's going to die. That's skin necrosis. So when you have large elevations of skin, for example, in a facelift, you could be having small areas of skin necrosis. Typically, that will be self-resolving with just wound dressing changes. So that's very important to know as well. The scars could be widening. The scars could be tough sometimes. A scar is a little bit on the hit or miss. I mean, you can do everything you can to have the best possible scar, but you can end up with a poor outcome there. So that's something you just need to discuss before. And know also if in the family there's scarring issues, keloids, hypertrophic scars, and such. Asymmetries, well, nobody's perfectly symmetrical, but we always shoot for symmetry as much as possible, of course. And so you could be dissatisfied with for example, on a blepharoplasty, addressing some of the excess skin on the eyelids and having not the exact level. So, but you could retouch that. You could take a little bit more on the other side and make it more symmetrical as needed. Ongoing misgendering, I didn't touch that, but it's important also. You're going through that surgery having very hopes and expectations. What if, you don't get what you expected originally? Now you've gone through all of that surgery process, and it's been a long recovery, and you're not happy because you feel that you're still getting misgendered. We need to talk about this as a possibility. How are you gonna handle that? So tracheal shave or laryngochondroplasty, that's the reduction. It's not the removal, it's the reduction of the Adam's apple cartilage, which is the thyroid cartilage that plays a role also in the voice box. And that's important to know and understand and say to patients, because if we do remove too much of that cartilage, there's a risk of changing a little bit of how the vocal cords are moving, and you could lower the pitch of the voice, which is not something you want to get when you're feminizing, of course. So you want to do as much as possible to flatten it as much as possible. You can take some of the two horns that you have on either side there, and you can really get to the peak, the projection, the most projected part in the midline to try and flatten it. But you will always feel it, and you have to, because, like I said, it's part of your vocal mechanism. Voice feminization surgery, so that's a different program. At Jairus, we have started to offer it. It's an ENT surgeon who's doing it. I don't know much about it, but I know there's two different approaches to do that, internal or external. So breast augmentation, that's when, an individual comes in and is not happy with their breast tissue as grown with hormones. So we'll discuss the different options. We'll talk about different things. One of the things important is to understand what the footprint of the breast is, which means this is the takeoff of the breast on your torso, and I can't change that. This is where it is. There's a fold medially and a fold laterally and a fold underneath there. I could give the illusion that the breast is closer together. Most patients actually complain that their breasts are too far apart, so we can give the illusion by elevating more skin in the midline and placing a wider implant so as to get that elevated and have a better cleavage. So we can do that. But then we have to discuss the volume we're going to be looking for to do these kind of things, because a breast implant has a single volume and a projection. The more wide the implant for the same volume, the less projected it's going to be, right? So the more narrow, the more projected. That's when you hear, I want a high projected implant. This is a high projection. This is a moderate plus, blah, blah, blah. So we can talk about that depending on the width of the torso as well. This is an example of what it looks like. And you see, we didn't have much to start with here in this patient, and she wanted to be fairly bigger than what she was, and so we went for implants that were 650 cc, which sounds very high when you compare to the cis population, because they have more breast to start with. So you have to reassure them and say, it's okay to go in the 657 or sometimes even 800 cc range, which is the max in silicone implants with the manufacturer we work with. So very important to know. Two types of, do I mention that somewhere? No, main two types of implants are saline filled or silicone filled. Both implants have the same outer shell, which is a shell of silicone. So for somebody who says, well, I don't want to be in contact with silicone, so I'd rather pick the saline implants, you still have to say, well, you know, your body's going to be in contact with some silicone because the outer shell is made of silicone, but it's not going to be that liquid silicone that you might be afraid of that would go if there's a rupture and go around in your lymph nodes and stuff like that. So you need to mention that. I would say that, of course, the saline is natural in that what it's in there, and that if there's a rupture, your body just reabsorb it, and that's it. But the cons of the saline a little bit is if you were to hold the implant like this from the top, you would have a lot of little waves at the bottom part. That's called what we call the ripples of the implant. So you end up, especially in very thin individuals, seeing those little waves here that sometimes drive them crazy, and they want to switch out to a more cohesive implant, more thicker, sort of like a honey, you know, base, because that's what the silicone, the highly cohesive implants look like a big, you know, honey. So they may want to switch for that. The silicone, though, because nothing is perfect, you won't see if there's a rupture if you don't look for a rupture. So you need to send your patients at least 2 to 3 years to get an ultrasound. After, you know, probably after 5 years, you should be doing that. Could be good as well that would be a good way also to keep the patients in a program for breast cancer screening, because they're going to have the ultrasound made no matter what, to look for other reasons, and then you can maybe catch a very early lesion. So I think it's a pretty good thing to do. All right, moving on to genital surgery. We could do several things. We could do isolated orchidectomy and or scrotectomy, or do that at the same time as vulvoplasty. That can be done at the same time of a neovaginal, which makes it then a full vaginoplasty. The orchectomy, I mean, we see patients who want isolated orchectomy, sometimes because the list to get to the vaginoplasty is too long, and they want to get that done first, but also sometimes because they just want to have no testosterone and don't have no plans on getting to a vaginoplasty. But the wishes could change also over time. Usually you won't remove skin. You'll do a midline incision and then ligate the testicle cords, remove the testicles, and you'll be closing on a midline incision, which allows also a surgeon to perform a vaginoplasty at a secondary time if needed. In some cases, we do encounter patients who do want a scrotectomy, so removing all of that extra skin and closing really as a flat area there. I have one patient right now that really wants to have this procedure, so I just need to make sure, it's my role to make sure that she understands that, does she want to have a vaginoplasty or not, because I'm going to lack tissue if I have to go back there. And this is going to be 100% skin graft then, with a more visible scar on the thigh, when we could potentially be avoiding it. But if she's positive, at least for now, then we'll move with that. So it's always the same thing, it's informed consent is a conversation with the patient, what they want, what the expectations are, and what you can offer. And you have to be realistic also on what you can offer, where your limits stand, and what complications are attributed to specific types of surgery, so you can really counsel very well patients and then make that decision together, because now you're a team. There's the surgeon and the patient, and we move together and we embark on that. But we're going to be together as well as there's complication. We're going to deal with those complications. You need to know all that. I need to explain to you all that, and then we need to choose the best pathway for you. For when we talk about vaginoplasty, the most common technique, and you may hear peritoneal vaginoplasty and everything, but all of those techniques, no matter what type, will start with penile inversion. So you'll use the skin of the penis to tack it down and invert it and start the beginning of lining of a canal. But you won't have enough skin to line the entire canal. There's some rare exceptions. But so you'll need the extra tissue there. And so the tissue, that's when you could have peritoneal, which means with a robot from up top, you're going to be dissecting a leaflet of the abdominal wall from the inside, and then push it down in the vaginal canal so as to line that extra part of the canal. or you could be using scrotal skin in the form of a graft, or you could be using even a piece of colon. So, but to use colon vaginoplasty, usually that's reserved for secondary deepening. We don't do it as a primary intervention because it's more morbid. You get to, you have to cut bowel, it's more, you may have encountered more complications, and also patients complain of more discharge because the bowel is producing a lot of mucus there. Peritoneum has been said to be a good newer sort of option because it has been described as self-lubricating, potentially, people do not advocate for less need for dilation in the long run. I am not entirely sure that this is, we'll have to wait for long-term outcomes, but there's more teams doing that and they're studying their outcomes, so we'll see. But for now, it doesn't seem that the dilation schedule would be that much different. Hair removal prior to surgery could be done. For us at GRS, it's not a necessity, but we have to tell patients that we will do everything possible on the scrotal skin to burn the follicles that we see, but that there could be hair growth afterwards, in the postoperative period. And we do see patients who do have hair growth. For the most part, it doesn't bother them, and it's very far back in the cavity, and it's not much. There's a few patients for which it's an issue, and so we can do something afterwards, and we can go back in there and reburn those follicles. But so if you want to make sure 100% that you're not going to have any hair regrowth in the cavity, then you want to do electrolysis and do permanent hair removal prior to surgery. We had this conversation yesterday with Josh Safer about hormones during vaginoplasty and should we be stopping or not. I know the endocrinology world says it's safe to keep the hormones, and I think we just need to incorporate it in our practice. It's just that, as surgeons, we're just freaked out of the possibility of having a pulmonary embolism because we put patients in stirrups and they stay in bed and they don't move as much within the first few days. We don't give any prophylaxis. We don't give any heparin because of the bleeding risk. So it sounded like, what are we going to do with the hormones? So everybody went on the boat of we're going to stop the hormones. But we're slowly getting back on that now, seeing that there's more and more bulk of evidence showing that probably it doesn't change. But what it does change is definitely the way the patients feel because they hate stopping the hormones, of course, and I think we need to get on that. There's different operative peri and post-operative protocols depending on the different teams. It varies widely for different surgeons. For example, we don't give heparin, but we do use the mechanical DVT compression boots. There's always a vaginal packing because, like I said, it's going to be lined with some additional tissue that needs to be incorporated in the neovaginal canal. So you need to keep a good pressure applied to inside the vaginal cavity that you just dissected, and so you'll find that in most places, either as in a form of a packing or we just use gauze wrapped on themselves, and then we put them in a condom, and then we insert and then we stitched it on the skin so it doesn't fall during the first 5 days. And then as soon as we remove, at least at GRS, as soon as we remove that vaginal stent, we start dilating. Because there will be a tendency from the body to want to contract and close that, considered as a wound, sort of. So you will have to fight that contraction and then dilate quite a bit at first, which is, what patients call a full-time job for the first few months because it's 4 times a day. It's a lot. You want to have patients also up and about the very first night of surgery because of that risk of DVT. So that's, again, the lining options. It's just to summarize what I just mentioned about the colon versus the peritoneal flap versus a skin graft. And that's how it would be looking like. But you see that, again, the penile skin is always found. So it always will make the beginning the introitus of the cavity, and then you will lengthen as needed with additional tissue, either from the peritoneal flap or from the skin graft. So we keep a Foley catheter. By the time, during the time the vaginal stent is in place, of course, you wouldn't be able to go and pee on your own. But as soon as the vaginal stent is removed, then we try to remove the catheter. Sometimes there's too much clots around, too much swelling happening around. Yep. I went a little too fast. Yeah. You guys good? So for urinary, you can have issues with the urinary meatus where you're going to keep that Foley catheter inserted for an extra week as needed because all the swelling makes that opening tough for patients, and you don't want them to have to strain on the toilet bowl doing that because they will cause some bleeding. Any Valsalva will cause some bleeding. So also bowel regimen is going to be very important. You don't want to raise the central venous pressure as it's going to cause bleeding. Douching every single time after dilation, very important at first to know that it's going to be a lot of cell debris, it's going to be a little bit of, it's going to be blood tinged, it's normal. The skin graft covers the most part of the inside of that cavity, but still there's some raw areas that you will have that will have a tendency to have a little spotting here and there. So this is something you have to mention because it could be pretty scary when you go home. Now you're discharged from the hospital and then you have to change your pads and you keep seeing blood even 1 week after surgery and you're thinking that you're bleeding actively. So you present to the ED and the ED is providers are not trained and that treat you very poorly and that, do all sorts of stuff, admit you, give you wrong antibiotics, whatever. And sometimes call us. Thank God, so we can be in touch with them. But so training is not only. I don't know if there's any ED providers in the room, but there should be. There should be, right? So and that says it all actually that there's no ED providers in the room. But and then we tell them that they can start experiencing on their own after a couple of months, and then they could have intercourse after 3 months. But it's very important that they actually start on their own with mirror feedback, just to make sure that you rewire a little bit your brain to your new anatomy as well, so you can look at different zones and new erogenous sensations that you're going to have. So the dilation is really a key part of a vaginoplasty procedure, and most patients who decide to have just a vulvoplasty, which means no canal, actually it's because they don't want to have to go through dilation because it's too much of a strenuous process for them. To desocializing for some, thinking, well, I see my friends all the time, I'm out and about, I won't be able to dilate 4 times a day. I don't want to do that. So then, okay, it makes sense. But if you're going to have a vaginal canal, you will have to keep it open with that dilation. I cannot say enough good things about physical therapy. I wish, it was more covered so that we could be sending all patients, even pre-op, to the pelvic floor therapist. They do an amazing job. I was at Mayo Clinic before, and we were sending all our patients to the physical therapist there, and she would be just working on muscle relaxation and expecting, this is what you're going to feel. I want you to start feeling what it means to relax your pelvic floor. Actually, she gives a course where she asks everybody to breathe and do a bunch of stuff, and you're starting to realize that you can also relax your pelvic floor, which I didn't know I could. So without needing to be on the toilet. So it was an interesting experience. But so, and I think just having the knowledge of that anatomy that we just don't realize in the everyday life is going to be life-changing after you have surgery, because we cut some of those muscles. You're going to have pain at that level. So if you've learned techniques that relax those muscles ahead of time, you're going to use those tools after surgery, and it's going to help. So it can help also to dilate without pain, because you're not going to contract as much, because it's painful. And you have patients who have gone, through sexual assaults as well. So now they have to insert that dilator. It can remind them of a lot of things that they don't want to be associated to anymore. So they contract, and then it's going to be a painful dilation, which then it's going to bring them in a circle of, again, living that again and again. And, you're chasing your tail here, it's so physical therapy really does magic for that. That's just an example of, different days, but you see that the first few days we'll get over the anesthetic, the surgery, we treat the pain, start moving more normally. But after day 5, that's when really the work starts. We remove the dressing and we'll start dilating at day 6. So the way we have things set up at GRS is that we have the convalescent home that's just attached to the hospital, so we keep patients for a week. It's a nice add-on because patients need to be around other community members, but also be around nurses who are going to be teaching them to do the dilations. There's a bunch of things to learn when you have this type of surgery. You don't want to be alone and be discharged on day 2 and then be left to yourself, with just a little booklet and what is instructed to do. I mean, that's terrible. Sitz baths and douching, that's just to care for all the little debris that I was mentioning after vaginoplasty, but also hypergranulation. Hypergranulation happens in pretty much every patient. That just means it's just your normal scarring, but just happening a little bit more and causing little sort of raspberry tissue that's very friable that could bleed. It could get infected as well. And so you treat that along the way, if you have some, with silver nitrate. And you redo that every 2 weeks. So that's what the dressing looks like. At first, it's stitched on the skin. And when you remove it, it's something that you have to manage as an expectation at first, too, is it's not going to look the way you want right away, right? It's going to be very swollen. It's going to be ecchymotic. You're going to have a Foley catheter in there. And then the stent here is still in place, as you can see. Then you'll start the dilation, and I'll show you. This is what it looks like at first. You see that little white thing above the dilator? That's a little piece of gauze. We have to pack gauze in there just on the new clitoris and the labia minora that's made out of urethra because it tends to bleed profusely if we don't really pack well. So that stays stuck for a while on that tissue because it's raw. And if you were to pull on it, it would be bleeding massively. So we ask the patients to keep that, and with the sitz bath and the care they're going to do, it's going to fall on its own within the next few days, sometimes weeks. This is kind of results that we can expect. So, C being for the clitoris and the clitoral hood. You can see more of the clitoris really in the center on the right-hand picture. The labia minora is made out of a urethra that's spatulated open. That's what gives that pink, shiny look in the middle. And then V being the introitus of the vagina. And you could see that there's some scar formation at the introitus there. And this is why, it's gonna, if you leave that scar, it's gonna keep raising to the point that you won't be able to insert anything anymore. And so this is why every single time you have to really dilate and push a little down to keep that opening open. Complications can be pretty bad for vaginoplasty, and the most dreaded complication is to perforate the rectum while you are dissecting the vaginal cavity. You are essentially dissecting the cavity between the prostate and the rectum, and there's literally no space there. So you have to create a new plane in a spot that doesn't exist. So you're very much close to the rectum, and it's very hard. It's very easy to get in there. The more you do it, the less risk you have, of course. Urethral stream abnormalities, you can have that, to some level of that for the first few months after surgery. That's almost expected because of all the swelling that you have after surgery, so that's pretty normal. Stenosis could result from a lot of different things. Like I said, if the dilation is painful, you're gonna stop dilating, you're gonna dilate a little bit less, and the less you're gonna be dilating, the more scar tissue you're gonna have. So most times it happens at the introitus, the opening, but it could be happening also along the canal, and then you would have to fix that where it is. Typically what we do is we wait for a few months to see how it settles, and then we re-intervene and we do a secondary deepening. We do little plasties to reopen the ring if there's a scar tissue ring at that level. So you see wound dehiscence, 12 to 33%. I just reviewed out actually more later than that. I think for dehiscence, you can expect as much as probably 75% at the posterior fourchette there, where at the entrance of the vagina, there's tension. It's a fresh wound, and you're putting dilator in with, lube on there. So you're rubbing. I mean, there's no surgical wound that we treat that way, right? But here we have to keep the opening. So this is why you're going to encounter some issues with the incision, and that's okay, as long as we know it. We treat the pain so that the patient can keep dilating. Sometimes it could be very impressive to see those wounds, like a little hole in there. But you have to tell patients you have to keep dilating. We'll use xylocaine gel. We'll use different things. Put the dilator in the fridge maybe to try and help with the swelling. But we got to keep dilating. This is the hypergranulation I was mentioning. That's sort of like a raspberry tissue. You can see it here, very friable. And you would be using a silver nitrate, and that would sort of chemically burn that and take it down, and it would be healing on its own. For revision, well, you have to address, of course, the problems that you have. So is it cosmesis? Is it urinary issues? Is it because you have a stenosis, so tight introitus, or is the stenosis more on the canal? So it means that you have lost some depth. Patients can keep track of the depth with their dilators because there's dots on them, so you can see at what dot you were, and so you can see if you've lost some. And so this is when you would be talking about secondary deepening, and that's when you would be using other options like a colon vaginoplasty, for example, because you have to rebuild the canal in there. You don't have much good options. You can't be using just a skin graft. It would be just recontracting again. So you need to bring something that's well vascularized, and a piece of intestine, and the colon actually works well in that indication. So those are the complications that we talked about. So I think maybe we should do a little bit of questions talking about now the feminizing surgeries before we move on to the masculinizing.
Hi, my name is Bonnie. I'm a marriage and family therapist, but I'm also a neurofeedback provider. So I'm very curious about the sensory motor rewiring and what kind of neurofeedback you see people going through. And is it QEEG driven, or is it something more specific?
You're talking about when after vaginoplasty?
Yes.
I don't know the specifics. I just know that it's something we use in facial palsy to help in retraining the face to move, right? When we have like a Bell's palsy, for example. Mm-hmm. And it's been helpful just even to have patients to reappropriate their anatomy, for example, like where is my clitoris? If I touch that zone, does that stimulate like if the feeling I had it when I was touching the glands of the penis, or is it a different feeling because I'm touching a different part of my body as well? Urethra can be sensate as well. So how does that integrate when I touch? What do I feel? And so that's kind of what I mean, but I don't know the specifics.
So it sounds like more like a biofeedback actually, versus like a stim or a training.
Biofeedback, yeah.
Okay, thank you for clarifying.
Hi, my name is Rory Carr. I'm a family nurse practitioner in Vermont. I was looking at the slide regarding the dehiscence that you're sort of expecting, and then thinking about the risks for a rectovaginal fistula and wondering at what point do you stop pushing the dehiscence and the dilating because you're worried about the risk of a fistula? So
the fistula will not really happen from that wound. The fistula really occurs with a surgical injury, Okay. If you have a good integrity of the anterior aspect of the rectum and you have not been going through that and it's full, there's no chance that your wound, even keeping dilating, is going to end up in a fistula. If you have a fistula, it means that there was a unrecognized, maybe even tiny hole that ends up then in a small fistula that could be causing the wound, because then you have an infection because there might be a little bit of stools coming in that new vagina, but not the other way around. So I'm not concerned about that.
And then is there any role for vaginal estrogen cream in the postoperative period?
There could be. Yeah, there could be, and we do prescribe sometimes. We do also prescribe for patients who don't experience enough sensation on the clitoris, sometimes testosterone screams as well. But
thank you.
Hi, my name is Sean. I'm an adult nurse practitioner from New Jersey. I have a patient who had a vaginoplasty about 4 years ago. After 2 years, they stopped dilating, and they've said they don't want to go back to their plastic surgeon because they didn't have a good experience. And they said, I'm just asexual now, essentially. And they were wondering if there's anything, they feel like they've lost depth. Is there any amount of redilation or anything that they can do non-surgically to make up for the losses that they've had? They're very against colon
Yeah.
extension. Just kind of, what are the options?
Yeah.
Because I hate to tell someone, well, you can't have sex. Or, yeah.
Well, I think the first thing is to try and make her not feel guilty of not dilating, because there's always life issues that make you not dilate at that moment. So that's very important to just kind of move on. But that scar tissue is really rock hard. It's like concrete. You can't. Once it's settled, you won't be able to just go, even with tiny dilators, and then increase the size of the dilators.
Right.
It's just not going to work. So it has to be surgical. It doesn't necessarily have to be a colon vaginoplasty, because depending on the primary technique that was done, you could be trying to do just a secondary deepening with a skin graft harvested from the thigh, knowing that there would be potentially higher risks of getting another stenosis and maybe a more strenuous dilation protocol for that. But it's probably worth looking at and see what was done in the first place. But non-surgically, after 2 years, I think there's not a whole lot.
Okay, thank you.
Hi, my name's Anita. I'm a third-year family medicine resident in upstate New York. I had a question regarding after vaginoplasty. Is there any change in the length of the urethra? Is there any concern, like in the primary care setting, that there's increased risk of UTIs or any other sort of vaginal infections?
Yeah, we see that a little bit. We see probably a little bit more UTIs in that population as well. So, but you don't want to over-treat right away. So, we'll do the usual urinalysis and culture, and then we'll treat with the antibiogram. So I think we need to do that. But you will see it. Not dramatically, higher rates, but you will see it, because we have to shorten it. So if you will, you take the urethra being a tube, and then we have to cut it and split it open like this to spatulate. So now that upper part is going to be your labia minora. So all of this stays, right? And then now your meatus is here. Okay, so all of this part is still urethra, long urethra, but used as a different purpose, so exposed to outside. But that doesn't bring necessarily more infections. It's just the fact that the urethra on itself then is shorter. So then that's probably why.
Okay. And as far as vaginal infections, like, is there increased incidence of yeast or?
So no, not really, because, and you wouldn't necessarily find the same flora anyways than cis vaginas. So because it's a skin epithelium, right? So what we started to do is swabs and see what would grow when we have ongoing issues and wounds that we have issues to just treat with just regular saline douching and stuff like that, and see how we can improve. Metronidazole creams, for example, could be used as well.
Okay.
Yeah.
Thank you.
Hi, how are you? My name is Nelson Aquino. I'm a pediatric anesthetist at Boston Children's Hospital. My questions are focused on the perioperative care. So I saw your complication rate for bleeding and hematomas are relatively low. Do you utilize transacemic acid in your care? And number two, do you use any regional anesthesia to help with the postoperative
Yeah.
care?
So tranexamic acid, I really want to incorporate it as both topical and IV. For now, I use it topical only on more bleeding when it's oozing more that I really can't control. But I've had the experience at Mayo Clinic using it in breast reconstruction, and it was definitely decreasing the ecchymosis, swelling, probably postoperative pain as well. And we do use regional, actually, yes. We use Epimorph, a regional spinal anesthetic, plus sedation. So the patients are not fully asleep for that, but they can have various levels of sedation, as you know. But yeah, we use that.
How about epidurals?
That's what. Well, they do a long
Oh,
block.
they put a catheter along with the...
No, they don't leave a catheter in there.
Okay.
They just inject. I think the anesthesiologist told me like his expectation of pain control is going to give like at least 24 to 30 hours. So typically the first day when we start moving, they're doing pretty good. The second day it starts to be a little bit more difficult, but then from there it goes back up, and usually treated with oxycodone for the first 72 hours as an adjunct orally, and then switching to tramadol.
Okay, thank you.
Hi. Oh, can I?
We'll take. So I suggest we take one more maybe, because we have
Okay.
to cover the masculinizing. We have just half an hour left. Is that right? I speak too much.
No, you're great. Thank you. So what about sexual function with the neovagina? Can they have orgasm with vaginal intercourse? Would it have to be more manual? Can they orgasm still?
I wish we had more data on that, but the answer is yes, they can. For some individuals that definitely do relate that, either by self palpation or through penetration or other sexual activities that they have around the clitoris. But I think it's a lot of things, because during penetration there's also a straight shot to the prostate, and the prostate is definitely erogenous as well. So all of that works together. The only thing we know is that there's going to be more tendency to be able to orgasm if you were able to orgasm before surgery. So, but some the patients who were not masturbating before surgery, then you would have potentially more issues to reach that orgasm after surgery.
Sure. Thank you.
All right, so moving on to masculinizing surgeries, and I think the two main things here we're going to be talking about is mastectomies, and then talking about metoidoplasty and phalloplasty. So chest masculinization, you would remove the breast and, as needed, the breast tissue and the skin that's extra there. So depending on the elasticity of the skin and the laxity of the skin, you would choose different types of techniques. Mostly two big types. Either you have a long incision on the chest because there's a lot of skin to be removed. So you'll have what's so-called double incision. It's called double incision because you make one above and one below, and you remove an elliptical skin with the breast tissue. Or periareolar, which means that you're going to go around the areola and then dissect, off, so the volume that's underneath the skin, and keep the skin intact so it could redrape the chest in a flat manner. But that means that you have a small volume to start with, and your skin is going to be nice and flat after. So you can imagine an individual that has stretch marks, for example, or wider breast tissue. That's not going to work because there's going to be skin to be addressed at the same time. So that's mostly the two differences. We do it as an outpatient surgery center. They come in the morning. They go out in the afternoon. We do that under general anesthetic. I do local blocks as well during that surgery, just on the pec fascia directly with lidocaine and bupivacaine. We try to remove the drains because nobody likes drains, right? But I had too much seromas, so accumulation of fluid after surgery, because it's a wide pocket and the body tends to want to fill that pocket with fluid. So just putting a drain in there and keeping it for at least 5 days has been helping with mitigating the risk of having a seroma. And patients do prefer having the drain placed when they're under general anesthesia rather than coming to the office to have a seroma tapped every 2 to 3 days because it keeps reaccumulating anyway. So when we do explain that, they said, okay, I'm good with the drain. Then you want to have compression because compression is going to help also. So you get this big space, you've been lifting up the skin, and again, so the body will want to fill that with fluid at first, and you want to have the tissue stick back to the pec fascia. So putting that compression is going to help. It could be any type of compression, or it could be surgeon-dependent, patient-dependent. They could have a binder, for example, that you attach in the front, so you don't have to lift your arms up in the air, because we don't want them to do that at first because of the tension on the scars. But otherwise, just a simple ACE bandage actually works great, because otherwise they would have to buy a new binder for just the postoperative period, which is very expensive, and then 1 month later, they'd be very happy to throw it in the garbage and never use it again, which is great, because this is really the reward after that surgery. So, but this is why we don't want them to move also the arms. I'm sure you've all seen results where the incision was very wide, and it could be sometimes very thick. I think this has to be, it could be patient sometimes. family history of keloids and all that, but for the most part, it's really an issue with tension on the skin. So there was too much tension, and it starts spreading apart. So either it was too much activity or just too much tension on the closure by the surgeon. But so that's why we don't want to lift the arms up. Like I was saying yesterday, I've heard some crazy stories of people asking not to do that for 6 months. I'm like, okay, but I mean, you're going to get a frozen shoulder, and then you won't be able to lift at all, when you restart that. So I think that's very unrealistic. But at least 1 month of paying attention and then restarting gentle stretches and making sure that you follow what you're feeling. If you feel a pull and a tug, it means that you're probably too far. So you want to go gentle. Return to regular activities is the same thing. You're going to do starting at 6 weeks. But you don't want to start doing push-ups right away, right? So you're going to be starting, you want to go gentle on that, and then you can resume 2 push-ups. Lymphatic drainage, chest massage can be beneficial. A lot of patients ask, what should I do for a massage? So I always say, listen, you had the skin, the breast tissue, and the muscle. Now you just have skin and muscle, and this will want to stick together very hard, very strongly. So I show them on their skin of the abdomen here. You see how the skin moves here? This is what you need to get. You need to get that skin to be moving back again on your chest. That's all you need to do. So there's no magical way to do it. Up, down, right, left. It's just mobilizing the skin. So we always have the questions of what should I put as a cream when I do that? You don't need a cream to do that. It's really the mechanical effect of moving the skin around that's going to actually break the scars. On top of that, you can add some stuff on the scars, such as silicone sheets, to make the scar look better, but not somewhere else on the chest. So just on the scar, it will make it less red and less raised as well for a scar. There's vitamin E, there's a bunch of stuff, but what's been published, probably what works the most is silicone sheeting by just keeping a good hydration of the scar. That's what we know so far. And then you have those nerve tingling because we cut, of course, a bunch of nerves when you do those procedures. They will regrow to some extent, and they will re-give a gross tactile sensation, hot, cold, and pain typically. Never you will get that erogenous sensation of the nipple back, but you can have like a gross tactile sensation back. And it will tingle for a while. That being said, I just came out of the surgery room, and there's somebody, I forgot the group, but it was in the US, who's starting to keep the nerves as she's doing mastectomy, and then reconnect the nerves to the nipple areola complex that she grafts on the chest, and she has good outcomes so far. So maybe that's going to be a new venture there to try and keep that and recover that sensation. So that's pretty awesome. Complications, so mostly scar issues here, and if you have a complication right away, it's going to be bleeding, so hematoma. You'll go back to the operating room. You'll treat the bleeding, and then you'll move on with the rest of possible complications. It's going to be more mid and long term necrosis, but neuroma and chronic pain. So neuroma being just like those nerves who try to regrow, but in an uncontrolled fashion, it can give little spots, very painful spots. Infection and wound separation is actually, I agree, pretty rare. This slide is not from me, but it's pretty rare. So this is just examples of what it would be looking like. You see periareolar mastectomy, so very tiny incisions made underneath the areola there. We got rid of all that, the volume. If you look well, you can see that it's, especially on the left side, and it's a little bit more ecchymotic going to the axilla here, it's still pretty tight. So that's when I would start the massage, for example. It's time to release that. And if the patient is, a little bit squeamish at touching himself and not feeling good, then you can send them to a massage therapist and do that lymphatic drainage as well. That's an example of a double incision with a graft. Another example. Show different body types so we can see the different results we can get. So the hysterectomy part is done, of course, by gynecologists. So we don't do that at GRS. Maybe one day we'll incorporate it in our program, but for now it's not the case. I thought it was overnight. I learned yesterday in the course I was giving that actually now it's made outpatient, so it's great. All laparoscopic, it's awesome. Apparently there's not much pain either, right? Yeah, a little bit. Yeah. I was asking, do you guys use Exparel or not on your port incisions? Exparel? The bupivacaine liposomes, you know, like the long-lasting bupivacaine?
I just do like bupivacaine right before the incisions, but it doesn't.
Okay. And you what? I'm sorry. Yeah. Yeah. It's super expensive, and apparently people are starting to, you know, change their mind on that and saying it's not that magical at all. So this is why I'm starting to make my opinion and see. But we don't have it here, anyways. It's not approved yet in Canada. But I was using it a lot at Mayo, but Mayo doesn't really care about the cost, so. I can say that now. I'm out. So, you know, you guys know that better than me, so you could be teaching that slide. I don't have much to say on this, but genital surgery. So we're going to be talking about metidoplasty versus phalloplasty. And look at the right side, all the blue dots. What is a complete phalloplasty? It's a bunch of different steps. So getting rid of the vaginal cavity, lengthening the urethra, and then making a, so we keep the clitoris, we deepithelialize the clitoris, we bury the clitoris so it's placed behind the new phallus, so you could still keep that erogenous sensation. There's actually multiple nerves going to the clitoris, so you can divide one of those nerves and connect it to a nerve of the phallus that you're bringing, so that the phallus will have some erogenous sensation at some point. At least it's the hope that it's going to recover in that fashion. And so you can have, but you know, you can have different things done, and you don't have to have all the things done. So we have patients who want to have a phalloplasty without the urethral lengthening, which means they will never be able to pee standing through the tip of the phallus. That's because they don't want to go through all the issues with the urethral lengthening, such as stenosis and fistulas, because all of the issues we have with the phalloplasties, for the most part, is really from the urinary tract and from the fact that we're going from a short urethra to a long urethra. So for vaginoplasty, easier. You have the tissue here, you shorten the tissue. For a phalloplasty, you have to lengthen the tissue. So you have to bring more tissue. And every time you have to bring the tissue, it's like a plumbing, right? So you have to put a connection there. At the connection zone, it's going to scar down. It's going to close up. It's going to stenose. So metidoplasty is using your own tissue and relying on the fact that the clitoris will be enlarged by testosterone. And then you can then release that clitoris, lengthen the urethra so you can be peeing from the tip of the clitoris. And the phalloplasty has different means of bringing more tissue to make a phallus. So, like I said, depending of, you know, do you want a pee standing or not? What are your goals? Is sexual function an important goal? Do you want to have penetrative intercourse? Because metidoplasty is going to be too short to give you a possibility of achieving penetration. Then, if this is an important thing for you, you will move more towards the phalloplasty. And then, do you want to have also urethral lengthening and be able to pee standing? Or does that not matter to you? And we will do only the sexual function. It would be great if it was all in one stage and you'll be able to pee from the tip of the penis and you have a normal appearing scrotum and everything and it works well and no complication, but it's not that way, unfortunately. So if we want to simplify it, what you need to know is you want to bring tissue, and the tissue could be coming from different zones, different parts of the body. If you touch yourself here, very thin layers of skin here, so you can't, you know, it's probably the thinnest part of your body, that and the dorsum of your foot, but the dorsum of your foot is going to be too small to wrap it into a phallus. But here you have definitely a lot of tissue that you could be working with based on one artery that you would be keeping. So we'll raise pretty much the entirety of the skin from the forearm with the radial artery that will divide here in the intercubital fossa with the veins and the nerves. And then we'll transpose that to the groin, and we'll reconnect those vessels on the femoral artery and branches of the saphenous vein so that this piece of skin now can live off a different zone. It could be living off of your groin area. And what do we do with that bare arm here? Because you're looking at muscles. We're putting a skin graft on top of that. So, and the difference between a skin graft and a flap is that the flap has its own vascular supply, right? So you're taking the artery with. Whereas the graft, you're shaving the very superficial layers of the thigh, and then you apply it here. So it's going to scar, and that's when, it doesn't give that good of a scar because it gets very tight. You need to go through extensive physical therapy, and it's the main drawback of that technique, of the forearm, is that to have a very visible scar. So the number of stages varies depending on if you do urethral lengthening or not, because we don't do everything at once. It's a lot to ask, for your body to have the vaginal cavity obliterated, the vaginal mucosa removed, the urethra lengthened, the phalloplasty done with the flap transposed, and then to do everything and then put the penile implant and all of that. It would be a massive rate of infection. It would be more urinary complications, so we stage everything. We do the phallus first, then we work on the urinary tract, and then we do the implants last. So the flap, like I said, has its own vascular supply. It could be either a free flap, means that you divide here and then you reconnect with microsurgical techniques, or it could be a pedicle flap. And this is where you hear about thigh phalloplasty. So the thigh, if you take the distal thigh, so let's pretend this is my thigh and this is the groin, then you could be harvesting a piece of tissue from here, leaving attached a source vessel, and then rotating on that vascular leash, and so you would reach the groin. So you would not have to do microsurgical techniques, for example. And those are all the different flaps we can harvest from the body. And as plastic surgeons, we're used to do that to cover different zones after cancers or traumas or, any other purpose. So this is what it's looking like. Looking at the forearm, this is the forearm fully harvested, ready to be rolled on itself. And so it's the concept of having a tube rolled in a tube. So one tube is going to be the urethra, and that itself is going to be wrapped again one more time in the phallus. And so you have a tube in a tube. It's hard to see from there, but you see a bunch of things coming to the flap. So that's, you have the vascular supply, but there's also small nerves that will, because we'll keep that sensation, and we'll reattach those nerves to nerves of the groin and to nerves of the clitoris. So we can have both the tactile sensation and the erogenous sensation. Okay, so that's again different concepts of flap making. This is how you would do for like the scrotoplasty that we do at the same stage. So we're getting things ready to put testicle implants in the second stage or third stage, depending. Again, tube in a tube design. You see it on the upper left, so you'll see that taking the flap, it's fully dissected. You get the radial artery that provides the blood flow to that. So we've done a test before to make sure that the ulnar artery was given enough blood after surgery that the hand will not have an issue. And then you'll wrap that. So you see this, the first wrap is the urethra. We close that. Now you have your urethra. You can put a Foley catheter in there. And then we'll rewrap that one more time, because now that's going to be the shaft. So we'll suture that. And then after that cylinder is made, then we can work on details like the corona of the glans, for example. And we can, it's hard to achieve something else than the aspect of a circumcised penis, because we can't reproduce the prepuce. And then you're in setting, you see, and then you're ready to do your microsurgical connections there. This is examples of results. This is from my colleague Jens Burley, who works in Portland at OHSU. This is one of his patients. Staging, so like I said, you could be, he stages things a little bit different than we do. What we do is the first stage is really obliteration of vaginal cavity, harvest of the flap, connection of the flap, preparation with the scrotoplasty, and urethral lengthening to the point where now you'd be peeing from a spot just underneath your phallus, and then the urethra of the phallus is ready to be connected to that other dot. That will happen at the second stage once all the inflammation has gotten down, so we can control a little bit of the complication rates. come for a second stage, do that connection. 4 weeks later, the patient is able to pee standing, and if everything goes well and keeps being without any issues, no fistula, no stenosis, then we'll be ready to place an inflatable device, a penile implant and or testicle implants. You see urology complication as much as 41%, but some series show up to 80%. I mean, that's a lot. But the very interesting, actually, that we didn't mention on that slide is that the same series of patients who had 80% complications answered to the question, would you do that over again? 100% said yes. So it tells you a lot. So we got to keep fighting, to make things better, because it's definitely needed. This is just a placing of the erectile implants, and they're nowhere near perfect again, because they're not, necessarily made to go in tissue wrapped on itself and to give a good outcome. They can move a little bit. So you see again here, 41% of actually having to replace and reposition those devices. It works still, and patients can be happy. So again, postoperative care here for phalloplasty varies, but it's very more demanding because you're transferring a piece of tissue from somewhere else. If there was microsurgery, you got to make sure that the blood flows through the artery, keeping that piece of tissue alive. So you want to do Doppler checks every hour. If there's any issue, you go back to the operating room, you fix the problem. It's very intense, both for the patient, the nursing team, the surgeon. I mean, the first night after phalloplasty, I still don't really sleep well because, if anything goes wrong, I got to be fast and act fast so we don't lose the phallus. So. But yeah, it's the protocols can vary a little bit. And that's just a sexual function. I think we mentioned those studies, but they're not recent studies. And I think the problem with those studies is that we were lacking also good measurement tools. And I think right now we're starting to try and standardize a little bit more. There's the gender Q coming up. There's a bunch of other tools that are more specifically addressing trans population and asking specific questions, because those ones were not. And then finally, just to finish, yeah. No. Yeah. Finally, regret is rare. Although haters will say differently. It doesn't matter to us, right? But we have to be open and to listen to it, of course, and to help to understand why, and then to help moving backwards with some surgical options sometimes if we can. But so I think this, the SOC8 also addresses that and seeing how we can work together as a team, again, in a multidisciplinary fashion to help those folks. So thank you, guys.
So a couple things.
No, I need to run it nude, but I can answer questions now.
Yeah. Some people were still out of the room when we started the lecture, and all of the pictures that you see in the slide deck have been signed release by the people who have their pictures used, but none of those pictures will be included in the slide decks that you receive. You'll only see the line drawings and things like that. So I just wanted to ensure people about that. Alex, maybe we can answer a few questions, and we'll end at noon, and then we're starting again at 1. Thank you.
Hi again, Nelson Aquino, Boston Children's. There's been established literature with enhanced recovery after surgery protocols, and so our team's worked on one with an ERAS for chest reconstruction. Have you seen that in any gender affirmation procedures? And my second question is, do you utilize TXA with your chest reconstruction Phalloplasties?
So again, it's very sparse when I use it. I just learned that there's a way to get a cheaper TXA because the TXA that we're getting billed at our hospital is actually outrageously too high of a price. And so I can't justify to use it in everybody for now, but I do want to. And for Eris, I haven't seen it, but that's definitely something I'm working on it myself for vaginoplasty because I think there's ways, and I definitely want to get on it because we can only improve and learn from each other to make that recovery better. And I think we're a high volume, so probably we can have a huge role to play in that.
Thank you.
Joshua Lumsden, physician assistant out of Seattle. Can you address the controversies around BMI cutoffs? Very often when patients are declined because of high BMI, the only reason it could be is fat phobia. But then when surgeons don't want to do it, the only reason it could be is the medical danger of doing that.
Yeah.
And it's a huge point of frustration for a lot of my obese patients.
Yeah, I understand. Yesterday we had a pretty hot, I would say, conversation in even our surgical room where there was a team from the UK who said they were not operating for any BMI above 31, which we were all looking at like we were say, well, in North America we won't operate on anybody, right? So, and our thought was like, this is just simply not true. And they were mentioning that you're going to have more very serious complications even after vaginoplasty, such as rectovaginal fistula. In our hands, that's not true, right? So we placed a cutoff just to a point where it seems that patients will have issues dilating and caring and for themselves after surgery in terms of performing hygiene and reaching the zone of the surgical zone. So we do even for genital surgery about 40, but sometimes it's 42 or for top surgery as well. Phalloplasty a little bit less, and that the only reason is if you have so let's say if you had an abdominoplasty before and now you're higher BMI, but there's nothing really in the way here, you could be doing it potentially, but the problem is if you have the abdominal pannus kind of pushing on the phallus, it's at risk of causing issues with the vascular connection that I mentioned. And also, to get to the femoral artery here, then the thicker the tissue, the more length you're going to lose actually trying to reach that deep femoral artery. And so you're going to lose on the phallus size as well because all of that needs to be vascular just to go down in there to provide the source of the blood. So I think it could be individualized. I think people tend to have guidelines that they want to publish on their website or just to guide patients. But definitely, I consider it, pretty outrageous to hear that, some patients get denied, and we just keep telling them, well, go back to the gym, and they barely go out of home because they just don't feel good, and so you just can't do that. But yeah.
So my name's Adrian. I'm a family practitioner from the UK. Huge problem with systemic fat phobia.
I knew this was going to
system,
happen.
by the way. Huge problem. So my question relates to trans feminine people who are going forward for gender confirmation surgery in the form of vaginoplasty. So sorry to be a bit retrospective with my question. But I wanted to ask, was there any role for the use of topical testosterone to improve or deal with the situation of tissue atrophy and things that we do see in some trans feminine people?
Definitely, and we do prescribe it.
Right.
We do use it, yeah. Even so for tissue atrophy, but also for lack of sensation on the clitoris. Sometimes, it could be a hormonal thing. So creams help. You have to have a conversation saying it's just topical because patients can freak out talking about testosterone again. So you have to explain what we're trying to do here, and that it's just topical. But yes, totally.
Over what sort of timeline preoperatively?
You mean post-op?
No, like in preparation for surgery to kind of optimize tissue elasticity and things like that.
That I haven't done. No, that I haven't done. Have you?
I've heard about it,
okay.
But I just wanted to know if you had an opinion.
And what did people mention? Were they getting good results?
Apparently so. Very limited numbers, but, say, for example, using it in the 3 to 6 months leading up to a surgery to kind of optimize elasticity in penile tissue and
Okay.
scrotal tissue prior to having vaginoplasty. So,
That's something I'm not opposed to. I mean, if it's proven to work, why not?
thank you.
Yep.
Yeah, Marshall Dahl, Endocrinology, Vancouver. Still on the topical testosterone theme. The opposite, a place for any role for topical testosterone for enlarging clitoris prior to metoidoplasty.
Yes.
Yeah, that's right. I'm certainly seeing that. What do you do? How do you do it? Or advise it?
So that's I actually don't do metoidoplasty. Dr. Broussard does all the vaginal the metoidoplasty. So I apologize. I don't know the answer to that question. I'm going to say I'll send it back to you as an endocrinologist.
So I mean, I actually have been asked by the
Yeah.
plastic surgeons to prescribe it. Have
What do
sort
you?
of a
What's your
recipe
protocol?
for
What
it.
do you prescribe?
I sort of what I used is having a look at the pediatric population with microphallus, where there's sort of an approach to topical testosterone there. I'm fairly new to the idea of using it and still kind of experimenting with that. I just point out that we're not using the sort of prescription preparations which are alcohol-based, like ouch,
Yes.
right? So tend to use Versabase, which is used, which can be used for compounding for often in postmenopausal women, cis women. And then there's, I'm still thinking about the concentrations. The little bit of feedback I've had is from the plastic surgeons is, yes, some growth. I mean, nothing's optimal, but better than zero. So I'm still kind of looking around. Which
It's
is
super
very,
interesting,
Yeah,
though.
very interested
Yeah,
to
yeah.
hear about how others
We do a little bit
centers are
of
doing it.
pumping as well, you know,
Yeah.
to help.
Sorry?
We do a little bit of pumping as
Yeah,
well.
can you
to
talk
help.
about how you advise people
So
on that?
there's like little devices that you can use to enlarge. Some patients like to use that, and some when they don't have the expected growth from just the replacement therapy, then they'll use that mechanical device for a couple 2 to 3 months prior to surgery, and we've seen some improvement. Again, nothing major, but I think maybe if we were combining both, the topical treatment plus that, maybe it could be even better.
You actually think that might be possible to do a real study because you got something to measure.
Yeah.
And a couple of interventions and approach. So pretty interesting. Just really curious to hear what was happening. Thank you.
Thank you, guys. So I need to. Do you want to? We
Just
do
a
one
quick
last?
one,
Okay.
Yes. I'm doing a mastectomy for masculizing. Do you recommend they start on testosterone first or afterwards, or does it matter?
It doesn't matter. To me, it doesn't matter. I think that the individuals I've had who were not on hormone were not sure they wanted hormones yet, or were not getting access to hormones, but definitely the breast issue was coming in their way, and they knew that this needed to be addressed. It didn't change much of the outcome in the long term. So I think if they're ready to move on with surgery, we can definitely propose that. Yeah. Thank you, guys. Thank you so much.